So thank you so much, Kwasi, our amazing chair, and to the Interest Committee for this invitation to talk on differentiated service delivery for children and adolescents living with HIV. And I'm going to particularly focus on HIV and mental health. I'll start by making the case for integration of HIV and mental health services for young people. I'll give an overview of Zhandiri and how we approach this. I'll talk about some of the evidence from both research and program data, and then how this evidence has been used to inform the scale-up of Zhandiri and peer-led differentiated services. I'm going to start with talking about Ruth, who is 15 years old, living with HIV. This is a self-portrait. It's a painting that she did herself as part of a qualitative study. I'll carry on. Shout out to them, they're impressively quick at bringing it back. So anyway, so back to Ruth. So this was a self-portrait she painted. She was involved in a qualitative study we conducted with young people living with HIV diagnosed with depression. It was a body mapping study that we used, that methodology. And what she said is, you may see me smiling, but I am dead inside. Ruth had access to ARVs, but her life story was one of rape, orphanhood, poverty, lack of hope for her future. So as I say, she had the ARVs, but the success of her treatment was really depending on the fact that we needed to address the broader issues in her life for her health and well-being. And this is what I really want to talk about today. If we are to address this persistent gap in viral suppression for children and adolescents living with HIV as compared with adults, yes, we need to keep pushing for TLD rollout and optimal regimens, but we also need to be thinking about young people's mental health. And as was raised earlier, I think the more we approach this 95% suppression in young people, that remaining gap is going to be about mental health and these really hard, challenging situations that we need to address. But of course, we're not just talking about mental health to achieve viral suppression. This is about young people's quality of life. So until fairly recently, the body of research describing the prevalence of mental health in adolescents living with HIV was largely coming out of high-income countries, but fortunately that's changing. And as you'll see from this range of studies, although there's a range of prevalence data here, all of them indicate or confirm that there's high prevalence of mental health conditions among adolescents living with HIV in this region. Here's some data of evidence from Zhandiri, and way back in 2004, this is very much why Zhandiri was established, young people were telling us way back then, as were being rolled out, we need more than medicine to thrive. In 2010, we conducted a study with Sesha in Zimbabwe that confirmed 65% of adolescents living with HIV were at risk of common mental disorders. And perhaps not surprisingly, this correlated with poor adherence to art. In 2016, I'll do my best to remember. In 2016, adolescents living with HIV with a high viral load told us that this is because of their mental health. And they attributed their poor mental health to the relationships in their lives with families, peers, and healthcare workers. And you'll see this is a recurring theme as I talk. So they were describing their experience of living with HIV was very much a relational issue, and that if we could intervene and support these relationships, then we could improve mental health and in turn adherence. In 2016 also, they told us that cats, who are the peer carders I'll be talking about, were critical in reducing poor mental health. Healthcare workers told us that despite this prevalence of poor mental health in the adolescents they were caring for, they lacked confidence to address this. And much more recently, a trial that I'll be talking about, the baseline study confirmed, again, this correlation between high viral load and poor mental health. 35% of young people with symptoms of common mental disorder had a high viral load. This is all confirmed in a global consultation that we conducted on behalf of WHO as part of the evidence towards the recent service delivery guidelines. We consulted with 388 adolescents and young people across 45 countries, and young people told us unanimously that psychosocial support is transformative across all HIV outcomes, not just treatment, viral suppression, but testing right through to ART initiation, adherence, retention, suppression. They said it should be multi-component because it should be a package of care that addressed their different needs, and it should be differentiated because, of course, they all have different needs and experiences, and this consultation was across different regions of the world. They said it must be sustained over time, so not a short-lived intervention, but the psychosocial support and mental health services needed to be there on the good days and the bad days. And as their lives evolved, they needed to be able to access the support as and when they needed. And they said again, it should be delivered by peers, supportive healthcare workers, and trusted adults. And the evidence from this consultation directly informed, it was included within the evidence for the new WHO guideline, which is very exciting. It strongly recommends psychosocial support and mental health services for adolescents to improve HIV outcomes. If you're interested in more, there's an animated film we put together with these findings. You can find that on YouTube or come and ask me. This was also echoed. The need for constant engagement and support was echoed within a consultation that USAID and Youth Power Learning conducted in 2019. They wanted to explore young people's perceptions and experience with MMD. Again, they described advantages and disadvantages. The advantages were about fewer clinic visits, saving time and money, fewer disruptions to their busy lives, fewer opportunities for inadvertent disclosure by minimizing the visits to the clinic, and incentivizes adherence and viral suppression. The disadvantages, though, were fear of poor adherence through reduced support, storage challenges, and less frequent interaction with peers because they had less opportunity to interact. What young people wanted was intensified, friendly, confidential support from CATs, peer counselors, and nurses. So how does Zhandiri approach this? Zhandiri means accept me as I am. This is the name that young people came up with back in 2004. And our goal is health, happiness, and hope. So it's really a comprehensive approach to health and well-being for young people living with HIV. And we try to achieve this by influencing multiple domains in their life to achieve this. Not just diagnosis, art initiation, and suppression, but also the other factors that influence their health and well-being. And we do this through 7 complementary pillars, which I won't go into, but I'm going to focus on service delivery and the evidence. But the important thing is that young people themselves are at the forefront of all of this work. So Zhandiri's service delivery is peer-led, differentiated care. What we do together with the Ministry of Health and Childcare in Zimbabwe is train and mentor HIV-positive young people, 18 to 24 years old, as community adolescent treatment supporters, or CATs as we call them. And this has evolved over the years into the Young Mental Mum program. So CATs that become mothers have then evolved into the Young Mental Mums, specifically focusing on pregnant and breastfeeding adolescent girls and young women. CATs and YMMs have been adopted by the Ministry of Health and Childcare for some years now. They are integrated within the healthcare facilities, supervised by the healthcare workers, and the technical assistance is from Zhandiri, but this is really ministry-led. And collectively across Zimbabwe, they're supporting 68,000 children, adolescents, and young people living with HIV. They provide their services across the community, clinic, and digital platforms. The digital MPhil platforms were there, but understandably over the last 2 years, this has really ramped up and been a key part of supporting engagement and support during COVID. And as I've said, we're aiming for a range of improved outcomes. Yes, testing, art initiation and suppression, but of course, improvement in mental health, sexual reproductive health, protection, and secondary prevention. So how does Zhandiri fit in with the more traditional models of differentiated care? Well, essentially, wherever young people are getting their ARVs, however they're getting it, whichever model of art delivery they are in, young people are also connected with the CATs. And so then CATs, what they do with with the healthcare workers and Zhandiri team on a monthly basis is they look at their caseloads and they decide are they standard or enhanced care. And this essentially is determined by their clinical and psychosocial circumstances. They don't all need the same. So those that are standard are essentially those that are suppressed, they're engaged in services, psychosocially stable and well. Enhanced is everyone else that has a high viral load, missing appointments, they are pregnant, mental health conditions, protection risks, etc. So it's a psychosocial definition as well as the clinical. What do? They support literacy, and not just for HIV, ART, and viral load, but also for TB, SRH, mental health. They provide counseling that is based on CBT, so it is a problem-based therapy, as well as drawing on positive psychology and narrative therapy. They screen for mental health conditions and TB, and they identify red flags. Clients that they're concerned about, they ensure are referred either back to the clinic or to social welfare. They mobilize clients in need of a viral load test for TPT, for TLD switch, and they trace defaulters. They conduct index testing through the clients. They have this trusted relationship with their clients, so they help to identify siblings or sexual partners that are undiagnosed, and they distribute HIV self-test kits. For enhanced clients, they are a key part of the case conferencing and case management team. Where, as I've said, this is done in the home, health facilities groups, and by phone. When it's monthly for standard, and for the enhanced clients, we step this up to weekly. It's predominantly cats and the young mental mums, but as I said, for the enhanced clients, they really work together as a multidisciplinary team to ensure enhanced support from both health and the social protection side. This is a slide kindly shared by Anna Grimsrud and Lena Golob from IAS, just as another example of how cats are complementing ART refills and clinical consultations. We work with the Ministry of Health and Young People to develop a whole range of implementation tools, IEC materials, and resources which young people and healthcare workers use in their work to support standardized, evidence-based service delivery. And again, working with the Ministry of Health to support capacity building of healthcare workers, families, and the cats and YMMs themselves. So what do we know about how does it work? A few years back, we embarked on the Zhandiri Trial. This was a collaborative research study. We had lots of interest in the Zhandiri program, but people wanted more. They wanted empirical evidence that this worked. And there's a lovely commentary written about this by Anna Grimsrud, Kerry Pike, and Linda Gale Becker on this trial. So it was a cluster randomized control trial to generate evidence of Zhandiri's effectiveness and cost effectiveness. What we found in summary was a 42% improvement in viral load outcomes compared with adolescents who continued with standard public sector care after 24 months of follow-up. But we also found from the qualitative study and large process evaluation improved mental health outcomes, improved quality of life, confidence, treatment literacy, improved support from caregivers and health workers. And a key finding was that Zhandiri is greater than the sum of its parts. We're often asked, if you could fund which bit, what would it be? Would it be the support groups or the home visits? And the trial confirmed that it's actually the package that young people need because it's differentiated. It gives people choice. It gives young people options and meets them at their point of need. So although we found that qualitative improvement in mental health outcomes, it wasn't a significant finding in the quantitative data. And so we proceeded to a second trial with this was called the Zhandiri Friendship Bench Trial, and many of you will know the phenomenal program, the Friendship Bench, led by Prof. Chabanda. And so we collaborated on this, again, with the London School of Hygiene and Tropical Medicine. And we enrolled 840 young people across Zimbabwe, across 10 districts, and we randomized them to either CATS standard counseling or CATS enhanced counseling. And really what we wanted to find out was if we could give CATS a more systematic approach to the counseling or an evidence-based approach, would this make a difference? What we found in both arms was that CATS counseling, whatever they were doing, results in significant reduction in common mental disorders after 48 weeks. So among young people receiving standard CATS counseling, there was a reduction in symptoms of common mental disorder from 72 to 10%. And among those receiving enhanced CATS counseling, drawing on problem-solving therapy, there was a reduction from 68 to 2%. So fabulous outcomes in both arms. But where problem-based therapy was used to explore young people's broader needs beyond adherence and treatment, then this was even more effective. I will add, though, that problem-solving therapy was difficult for CATS and clients, and this came out in the data, because the solution element of problem-solving therapy young people's problems are so often intrinsically linked with the adults in their lives or beyond their agency to solve per se. And so what CATS and clients did, they adapted it almost to problem discussion therapy, as we're calling it. And what we found is that was incredibly therapeutic. This peer-to-peer engagement, when they were able to elicit problems that they were experiencing, discuss those for young people to feel heard and validated, and then to ensure that they got linked to other professionals for support was beneficial. So we've shown that peer supporters, CATS in our case, are effective in improving viral suppression and mental health. But I just want to flag, we need to really invest in supporting the peer supporters. So these are two papers we've written on this issue, and we came up with a trust framework, which I won't go into detail, but it just to emphasize that this isn't a quick fix. It isn't a cheap labor force. It isn't a cheap way to achieve our targets. And one thing that we do over and over again is to advocate for when you're doing this, it's got to be invested in. So have we translated evidence to practice? This is data from across Zimbabwe. As I said, we've got 68,000 young people in the program being supported. So across the Cascade, over 5,000 young people were mobilized through contact tracing and referred for testing. 15% of those were confirmed positive. 95% of those were linked to HIV treatment and care. And in the third 95, 98% of CATS are suppressed, 97% of young mums. And by the way, in the Young Mental Mum program, we have a 2.8% mother-to-child transmission rate. And 90% young people in Zhandiri are virally suppressed, and that's across the country. I also want to share a lovely case study we're very proud of in Zimbabwe. We're often told peer-led interventions aren't sustainable. So I just wanted to shout out to our National AIDS Council, who in 2019 made the bold decision, pioneering decision to directly fund CATS with domestic resources in Zimbabwe. So it's not donor funded, and they took this up in 37 health facilities in 6 districts. One of these sites was the former Zhandiri Trial research site. They employed a former CATS to coordinate this intervention with NAC and the ministry. And we have 98% viral suppression among former Zhandiri Trial participants. So this is domestic funded, government led. Beyond Zimbabwe, we've had the enormous privilege of working with governments and implementing partners across the region who have been really interested in learning more about the Zhandiri program in Zimbabwe. And we've had country delegations. Uganda led the charge on that, and we had a fantastic delegation from here in Uganda who came for a south-to-south learning and exchange visit. And now these countries have gone on to take up or integrate or adapt this approach within their national programs. Here in Uganda, they're YAPs. If there are any YAPs in the room, shout out to you. But yeah, collectively, there are 96,000 children and young people being supported by 3,000 peer counselors. A few things coming soon. We did embed a cost-effectiveness study within the Zhandiri trial, which is exciting, I think. The results are expected in July 2022, so coming soon, watch this space. We're just starting a mental health study looking at the Zhandiri character strength. So we've seen all these results, but we want to dig a bit deeper from a psychological perspective. What are the psychological constructs that determine young people's success? We're developing a screening tool and a CATS-led caregiver intervention as part of that. We're also starting an exciting initiative with the University of Buffalo, led by Prof. Morse and his team, and the University of Zimbabwe on an adolescent HIV mental health research training program, which will involve a virtual mentoring network to build research capacity and research studies on adolescent HIV and mental health. And we're collaborating with WHO on technical assistance to 21 priority countries to support adoption of the new service delivery guidelines. There are 2 papers coming up, which I thought I'd share. They're in press. They should be any time soon, just to look out for, again, that speak to this integration of HIV and mental health. The first one's very much linked to the evidence from the WHO new service delivery guidelines. A plug for IAS's DSD online course. This is free. So anyone interested in taking this up, check out the IAS's website. So if you're interested in finding out more about DSD. And another plug, coming up at the AIDS 2022 conference as a pre-conference, again focusing on DSD. So just to wrap up, we heard earlier from the wonderful presentation from Botswana about the importance of political will. Zimbabwe's Ministry of Health and Childcare have championed peer-led community interventions and really pioneered this, and we can't thank them enough, really leading the way with the National AIDS Council, as I said, and thank you to our fabulous partners and supporters, WHO, PEPFAR, who've really supported us to scale in the country, and all our other partners. But of course, particularly the last thanks goes to young people themselves who continue to show us what we can do if they're given the space, if they're given the support in terms of improving young people's health and well-being. Thank you so much.